So, common general principle of clinical pharmacology. And we explain the importance of pharmacokinetic analysis and present simple approach to this common topic. We explain how drug clearance determines the steady state plasma concentration during concentrate drug administration, and how characteristics of absorption, distribution, metabolism, excretion determine the time course of drug concentration in blood plasma during the following drug administration. The effect of different dosing regimes on the time course of drug concentration in plasma is explained. Population pharmacokinetics mention it briefly, and final section considers limitation to the pharmacokinetic approach. So, pharmacokinetics is a branch of pharmacology dedicated to determining the fate of chemical substance administered to a living organism, what the body does to the drug. In practice, this involves measurement and formal interpretation of changes with the time of drug and drug metabolite concentrations in plasma, urine, and sometimes other accessible region of the body in relation to dosing. It provides framework for understanding what happens to a drug when given to an animal or human, where it goes in the body, and how quickly that enables one to understand the effects that it produces. In contrast, pharmacodynamics, what the drug does to the body, describes events consequent on interaction of the drug with its receptor or other primary site of action. So, next slide. Pharmacodynamic research entry in dictionary of 1890 relating to the progress of effects of drugs, whereas pharmacokinetic studies only become possible in the later part of the 20th century with the development of sensitive, specific, and accurate physiochemical analytical technologies, especially high performance chromatography and mass spectrometry for measuring drug concentration in biological fluids. The time course of drug concentration following dosing depends on the processes of absorption, distribution, metabolism, and excretion. And we have short what ADME: absorption, distribution, metabolism, excretion. So, and the first step is drug absorption. Absorption is defined as a passage of a drug from its site of administration into the plasma. It's important for all routes of administration except intravenous injection, whereas complete by definition. There are instances such as topical administration of steroid cream to skin, or inhalation of bronchodilator aerosol to treat bronchial asthma, where absorption as just defined in is not required for the drug to act, but in most cases, the drug must enter plasma before reaching its site of action. The main routes of administration are oral. Drug is swallowed sublingual or the buccal. Drug is kept in contact with the oral mucosa. Next, rectal application to other epithelial surface, for example, cornea, vagina, nasal mucosa, skin. Next, inhalation, injection, subcutaneous, intramuscular, intravenous injection, intrathecal, intravitreal. And next slide show what is this oral administration of drug. Most small molecule drugs are taken by mouth and swallowed. Little absorption occurs until the drug enters the small intestine. Through non-polar drugs applied to buccal mucosa or under the tongue, absorbed directly from the mouth. Peptides and proteins subject to digestion, as well as epithelial barrier to the oral route, is not generally suitable to biopharmaceuticals, and despite ingenious pharmaceutical approaches to circumvent the problems, success has been limited. Factors affecting gastrointestinal absorption. Typically, about 75% of a drug given orally is absorption in first 1 or 2 or 3 hours, but numerous factors alter this. Some physiological and some to do with formulation of the drug. The main factors there are in these slides. I don't read it, I send this, you know. And next is bioavailability and bioequivalence. The term bioavailability is used to indicate the fraction. Short, you can see short, it's F. Oral administered dose that reaches the systemic circulation as intact drug, taken into account both absorption and local metabolic degradation. Fraction F. Fraction is measured by determining the plasma drug concentration versus time curves in a group of subject following oral and intravenous administration. The area under the plasma concentration time curves, you can see this short about AUC. Area under concentration time curves provides integrated measure of drug exposure, taking into account time as well as concentration. And F is estimated as AUC oral to AUC intravenous. Bioavailability is not characteristic solely of the drug preparation. Variation in enzyme activity of drug wall or liver, in gastric pH or intestinal motility, all affected. Because of this, one cannot speak strictly of the bioavailability of particular preparation, but only of the preparation in a given individual on particular occasion, and fraction determined in a group of healthy volunteer subjects may differ substantially from the value determined in patient with disease of gastrointestinal or vascular system, circulatory system. Bioavailability relates only to the total proportion of the drug that reaches the systemic circulation and neglects the rate of absorption. If a drug is completely absorbed in first 30 minutes, it will reach a much higher peak plasma concentration and have more dramatic side effect than if it were absorption over several hours. Regulatory authorities which have to make decisions about the licensing of products, there are generic equivalents of patented products require avoidance of bioequivalence based on the maximum concentration achieved. C maximal concentration maximum and time between dosing, and C maximum, T maximum, time maximum, as well as AUC, zero level of time. For most drugs, AUC 0 and C max must live between 80 persons and 125 persons, more than 100 persons of a marketed preparation for the new generic product to be accepted as bioequivalent. Next, absorption directly from the oral cavity is sometimes useful when rapid response is required, particularly when the drug is either unstable at the gastric page or rapidly metabolized by the liver. Glyceryl trinitrat and what are the drugs? Buprenorphine. There are examples of drugs that are often given sublingually. Buccal midazolam, effective and safe intravenous or rectal diazepam in terminating early status epilepticus for a child. Times from arrival in the emergency department to drug administration and to seizure cessation shortened, and the drug is easy to administrate. Drug absorbed from the mouth pass directly into the systemic circulation without in oral. Rectal administration is used for drugs that are required either to produce a local effect or to produce systemic effect. Absorption following rectal administration may be unreliable, but can be rapid and more complete than following oral administration, since only a fraction of the capillary drainage return to systemic circulation with a portal vein. So, next, different ways. Cutaneous administration is used where local effect of the skin is required. Appreciable absorption may non-ethels occur and lead to systemic effects. Absorption is sometimes explored therapeutically, for example, in local application of rub-on gels of non-steroidal anti-inflammatory agent such as ibuprofen. Most drugs absorb very poorly those unbroken skin. However, a number of organophosphate insecticides which need to penetrate an insect's cuticle to walk the absorbed through skin and accidental poisoning occur in farm workers, for example. Nasal spray, some peptide hormone analogous, for example, antidiuretic hormone and gonadotropin releasing hormone given as nasal sprays. Next, eye drops. Many drugs applied as eye drops relying on absorption, so the epithelium of the conjunctival sac to produce the effect. Maybe several examples. The cerebral local effect within the eye can be achieved without causing systemic side effect. For example, drazolamide, carbonic anhydrase inhibitors, there's given as eye drops to lower ocular pressure in patients with glaucoma. Next pathway, administration by inhalation. Inhalation is the route used for volatile and gaseous anesthetics. The lung-serving route of both administration and elimination. Rapid exchange resulting from the large surface area and blood flow makes it possible to achieve rapid adjustments of plasma concentration. Drugs used for their effect on the lungs are also given by inhalation. Usually it's aerosol, glucocorticoids, and bronchodilators given in this way to achieve high local concentration in the lungs, while minimum systemic effect and decrease side effect, common side effect. Next pathway is administration by injection. Intravenous injection is the fastest and most certain route of drug administration. Bolus injection rapidly produces high concentration of drug, first in the right head and pulmonary vessels, and then in the systemic circulation. Peak concentration reaching the tissues depends critically of the rate of injection. Administration by intravenous infusion using mechanical pump avoids absorption from the other sides while avoiding high peak plasma concentration caused by bolus injection. Subcutaneous or other intramuscular injection of drug usually produces a faster effect than oral administration, but the rate of absorption depends greatly on the site of injection and on local blood flow. The rate limiting factors in absorption from the injection site. There are diffusion through the tissue and removal by local blood flow. Absorption from a site of injection sometimes, but not always desirable, is increased by increased blood flow. Intrathecal injection. Injection of drug into subarachnoid space via lumbar puncture. Needle is used for some special purposes. For example, methotrexate for treatment patient with oncology pathology. Next pathway, intravitreal injection. Example is monoclonal antibody fragment that bind to vascular endothelial growth factor. For example, it's drug named ranibizumab. It's new drug. It's can be fusion protein, and we can to treat macular edema, choroidal neovascularization, intravitreal implants that slowly release corticosteroids, over a period of months used in macular edema. Next, I don't stop on this slide. So, one moment, maybe. Distribution of drugs. Body water is distributed into 4 main compartments. Water constitutes 50% to 70% of body weight, being rather less in women than in men. Extracellular fluid comprises the blood plasma about near 5% body weight, and intestinal fluid it's near 16%, and lymph near 1%. Intracellular fluid is the sum of the fluid content of all cells in the body. Transcellular fluid includes the cerebrospinal, intraocular, peritoneal, pleural, synovial fluids together, and digestive secretion, they're together. The fetus may also be regarded as special type of transcellular compartments. Within each of those aqueous compartments, drug molecules usually exist both in free solution and in bound form. Furthermore, drugs that are weak acid of bases will exist an equilibrium mixture of the charges and uncharged forms. The position of the equilibrium depending on the pH. To enter the transcellular compartments from the extracellular compartments, a drug must cross a cellular barrier. Particularly important example being the blood-brain barrier. And look on this slide, it's a scheme of blood-brain barrier. Concept of the blood-brain barrier was introduced by Paul Ehrlich to explain his observation that intravenously injection de-stained most tissue but not the brain. The barrier consists of a continuous layer of endothelial cells donated by Thai junction and surrounded by pericytes. The brain is consequently inaccessible to many drugs of low lipid solubility. However, inflammation can disrupt the integrity of the blood-brain barrier, allowing normally impairment substance to enter the brain, and can also disrupt drug efflux mechanism. Consequently, penicillin can be given intravenously to treat bacterial meningitis, which is accompanied by intense inflammation. Next parameter, volume of distribution. Apparent volume of distribution, you can see short VD. It's defined as a volume that vault contains the total body content of the drug. at concentration equal to that present in the plasma. It's important to avoid identifying a given range of VD too closely with particular anatomical compartment. Drugs may act at very low concentration in the K compartment that provides access to the receptors. For example, insulin has measured volume of distribution, VD, similar to the volume of plasma water, but exerts its effect on muscles, fat, liver receptors. They are exposed to intestinal fluid, but not to plasma. The plasma volume is about 0.05 liter by kilogram body weight. Few drugs, such as heparin, for example, heparin, confined to plasma because the molecules is too large to cross the capillary wall easily. More often, retention of a drug in the plasma following a single dose reflects strong binding to plasma protein. Is the free drug in the interstitial fluid that exerts pharmacological effect following repeated dosing. Equilibration occurs and measured volume of distribution increases. Some dyes bind exceptionally strongly to plasma albumin, as with Evans blue, such that its VD is used experimentally to measure plasma volume. Drug distribution in the extracellular compartment. The total extracellular volume is about 0.2 liter by kilogram, and this is approximate VD for many polar compounds such as vecuronium, gentamicin, several penicillins. This drug cannot easily enter cells because of their low lipid solubility, and they don't traverse the blood-brain or placental barriers freely. Many macromolecular biopharmaceutical, notably monoclonal antibodies, described in the intracellular space and access receptors on cell surface, but don't readily enter cells. Distribution through the body water. Total body water represents about 0.55 liter by kilogram. This approximates the distribution of many drugs that readily cross cell membranes, such as phenytoin, ethanol. The binding of drugs outside the plasma compartments or partitions into body fat increases VD beyond total body water. Consequently, there are also many drugs with VD greater than the total body volume, such as morphine, tricyclic antidepressant, galoperidol. Such drugs are not efficiently removed from the body by hemodialysis, which is therefore unhelpful in managing overdose with such agent. And the special drug delivery system. Several approaches used and developed to improve drug delivery and localize the drug to the target tissue. They include prodrugs, antibody drug conjugates, packaging in liposomes, and coated implantable devices. And what about prodrugs? There are inactive precursors that are metabolized to active metabolites. Some of the example in clinical use confer no obvious benefits and have been found to be prodrugs only retrospectively, not having been designed with this in mind. However, some do have advantages. For example, the cytotoxic drug cyclophosphamide becomes active only after it has been metabolized in the liver. It can therefore be taken orally without causing serious damage to the gastrointestinal epithelium. Antibody drug conjugates. One of the arms of cancer chemotherapy is to improve the selectivity of cytotoxic drugs. One approach is to attach the drug or toxin to an antibody directed against tumor-specific antigen, which will bind selectively to tumor cells. Trastuzumab, Mtines, and several other drugs have been approved by the FDA for treatment of skeletal cases of respectively metastatic breast cancer and Hodgkin's lymphoma. And next, packaging in liposomes. Liposomes are vesicle, very small diameter produced by sonication of aqueous suspension of phospholipids. They can be filled with non-lipid soluble drugs, which are related until the liposome is disrupted. Liposomes taken up by reticular endothelial cells, especially in the liver. They are also concentrated in malignant tumors, and several liposomal chemotherapeutic formulation commercially available. It's a sample of drug. There are amphotericin, doxorubicin, what other, vincristine, this drug for treatment oncology. Coated implantable devices. Impregnated coating have been developed that premium localized drug delivery from implants. These implants examples include hormonal delivery to the endometrium from intraurine device. It can be delivery of antithrombotic or antiproliferative agent drugs or radiopharmaceutical drugs to the coronary arteries from stent. Stents reduce the occurrence of the restenosis, but this can still occur at the margin of the device. Coating stents with drugs such as sirolimus embedded in surface polymer prevents this important clinical problem in this time. General aspects of drug absorption and distribution considered together with routes of administration, metabolism, and excretion covered in next topics next time. And the chemical chemical nature of drug makes no difference to its transfer by bulk flow. The cardiovascular system provides rapid long-distance distribution system. In contrast, diffusional characteristics differ markedly between different drugs, in particular ability to cross hydrophobic diffusion barriers is strongly influenced by lipid solubility. Aqueous diffusion is part of the overall mechanism of drug transport because it's this process that delivers drug molecular to and from the non-aqueous barrier. The rate of distribution of substance depends mainly on its molecular size diffusion coefficient, being inversely proportional to the square root of molecular weight. Consequently, while large molecules diffuse more slowly than small ones, the variation with molecular weight is modest. Classical small molecule drug mainly fall within the molecular weight range up to 1000 Dalton. And variation in aqueous diffusion rate have only a small effect on this overall pharmacokinetic behavior. Whereas biopharmaceutical typically much larger molecules. So next, of the Rose diffusion through lipid and carrier-mediated transport, particularly important in relation to pharmacokinetic mechanisms. Non-polar molecules in which electrons uniformly distributed dissolve freely in membrane lipids and consequently diffuse readily across cell membranes. The number of molecules crossing the membrane per unit area in unit time is determined by the permeability coefficient and the concentration difference across the membrane. Many pharmacokinetic characteristics of drugs, such as rate of absorption from the gut penetration into different tissues and the extent of renal elimination, can be predicted from knowledge of its lipid solubility. Ion trapping. Ionization and membrane permeability affect not only the rate at which drugs permeate membranes, but also the state distribution of drug molecules between aqueous compartments. Lipid-soluble molecules diffuse into cells where they can be metabolized. This may liberate functionally important changing metabolite, which is consequently trapped within the cells. pH partitional and ion trapping. If pH difference exists between body compartments, this can alter the steady state distribution of drug. There are weak acid or weak bases via its influence on their ionization. We have several important consequences of pH partition. Free base trapping of some anti-malaria drugs in the acid environment in the blood vacuole of the malaria parasite contributes to the disruption of the hemoglobin digestion pathway that underlies their toxic effect on the parasite. Urinary deficient acceleration excretion of weak bases and retard that of weak acid. urinary alkalinization, and increasing plasma pH, for example, by administration of sodium carbonate. Many cell membranes process specialized transport mechanisms that regular entry and exit of physiologically important molecules such as sugar, amino acids, metal ions, neurotransmitters. Two structurally released transporters, CLCs of importance in drug distribution, the organic cation transporters, OCTs, and organic transporter, OAT. The carrier molecular consists transmembrane protein that bind one or more molecules of ions. Change conformation and releases its cargo on the other side of the membranes. Such systems may operate purely passively without any energy source. And look where it's important. This different barrier in human body: blood-brain barrier, gastrointestinal tract, renal tubule, biliary tract, placenta, and the end. Plasma protein and T-cell partition of drug. In addition to the processes so far described, which govern the transport of drug molecules across the barrier between different aqueous compartments, two additional factors have a major influence on drug distribution and elimination. They are binding to plasma protein and partition into body fat and other tissues. At therapeutic concentration in plasma, many drugs exist mainly in bone form. The fraction of drugs that is unbound and pharmacologically active in plasma can be less than 1%. The remainder being associated with plasma protein. Seemingly small difference in protein binding, for example, 99%, can have large effect on free drug concentration and drug effect. Such difference common between human plasma and plasma from species used in preclinical drug testing and must be taken into account when estimating suitable dose for first time in human studies during drug development. The most important plasma protein in relation to drug binding is albumin, which binds many acid drugs, for example, warfarin, anti-inflammatory drugs. The amount of drug that is bound to protein depends on three factors. Its affinity for the binding site, concentration of free drug, and concentration of protein. I send this slide for you, and in practice, pharmacokinetics usually focuses on concentration on drug in blood plasma, which is easily sampled via venipuncture. Single plasma concentration assumed usually to bear a clear relation to the concentration of drug extracellular fluid surrounding cells that expresses receptors or other target with which drug molecule combine. This underpins what is termed the target concentration strategy. Individual variation in response to a given dose of drug is often greater than variability in the plasma concentration at that dose. plasma concentration, therefore useful in the early stages of drug development. And in the case of few drugs, plasma drug concentration also used in routine clinical practice to individual dosage achieve the desired therapeutic effect while minimizing adverse effect in each individual patient. So we can see to do therapeutic drug monitoring of an abbreviated short word TDM. Table show example of some drugs where therapeutic range of plasma concentration has been established, enabling TDM. Concentration of drug in other body fluids may add useful information. For example, in urine, cerebrospinal fluid, milk, saliva. Formal interpretation of pharmacokinetic data consists of fitting concentration versus time data to a model, whether abstract or more usefully physiologically based, and determining parameters that describe the observed behavior. Parameters can then be used to adjust the dose regime to achieve desired target plasma concentration and to record a device. Some descriptive pharmacokinetic characteristic can be estimated directly by inspecting the time course of drug concentration, plasma flowing, dosing. Important example illustrated more fully later as the maximum plasma concentration following a given dose of drug administered in defined dosing from maximal concentration and the time maximal between drug administration and achieving concentration maximal. Other pharmacokinetic parameters estimated mathematic from experimental data. Examples include volume of distribution and clearance. This approach applies both to classical low molecular weight drugs and to macromolecular biopharmaceutical. So qualitative aspects of absorption, distribution, elimination, very different pharmacokinetic parameters differ markedly. For example, antibodies have evolved to persist for long periods after exposure to antigen, and therapeutic antibodies commonly have low rates of clearance and long elimination half-lives consequence. We describe some phases 1 and phases 2, metabolism of pharmacokinetic. So maybe this, no, this. These two phases of drug metabolism emphasizing the importance of the cytochrome P450 monooxidase system. We then cover the processes of biliary excretion and intrahepatic recirculation of drugs and of drug interaction caused by induction or inhibitors of metabolism, drug and drug metabolite elimination by the kidney are described, and drug interaction due to effects on renal elimination considers. Drug elimination, irreversible loss of drug from the body. It occurs by two processes, metabolism and excretion. Metabolism consists of anabolism and catabolism. That's respectively the build up and breakdown of a substance by enzymic conversion of one chemical entity to another within the body. Whether excretion consists of elimination from the body of the drug or drug metabolite. Main excretory roads there are kidney, hepatobiliary system, and lungs. It's for gases, anesthetics, for example. Endpoints of drug metabolism. Animals have evolved complex system that the toxicity following chemical xenobiotics, and human has this detoxity system, including carcinogens, toxin processed in poisonous plants, drugs, special case of such xenobiotics and like plain alkaloids, they often exhibit trackley, for example, more than one stereoisomer, which affects their overall metabolism. Drug metabolism involves two kinds of reaction, known as phase first and phase second, which often occur sequentially. Both phases decrease lipid solubility, thus increasing renal elimination. First phase 1 reaction, for example, oxidation, hydrolysis, reduction. They are catabolic, and the products are often more chemically reactive and hence, paradoxically, sometimes more toxic or cancerogenic than the first drugs. Phase 1 reaction often introduce reactive group such as hydroxyl into the molecular process known as functionalization. This group will then serve as a point of attack for the conjugation system to attach substituents such as glucuronide, explaining while phase 1 reaction so often precede phase 2 reaction. The liver is especially important in phase 1 reaction. Many hepatic drug metabolism enzymes, including CYP, cytochrome P system enzymes, embedded in the smooth endoplasmatic reticulum. They often called microsomal enzyme because on homogenization and differentiation centrifugation, the endoplasmatic reticulum is broken into very small fragments and sediment only after prolonged high-speed centrifugation in the microsomal fraction. To reach these metabolism enzymes in life, drug must cross the plasma membrane. Polar molecules do this less readily than non-polar molecules, except there are specific transport mechanism. So intracellular metabolism is important for lipid-soluble drugs, while polar drugs as least partly excreted, unchanging in the urine. Cytochrome P enzymes, hem proteins, comprising a large family, superfamily of related but distinct enzymes, each referred to as cytochrome following by defining that of numerous and later. Cytochrome enzymes differ from one another in amino acid sequence, in sensitivity to inhibitors and inducers agent, and in the specificity of the reaction that they catalyze. Different members of the family have distinct but often overlapping substance specific purification and closing of cytochrome enzyme from the basis of the current classification, which is based on amino acid sequence similarity. Not all 57 human cytochromes involved in drug metabolism, but it has been estimated that cytochrome enzymes in families 1, 2, 3, maybe 70 to be 80% of all drugs. There are important variation in the expression and regulation of cytochrome enzymes between species. The pathways by which certain dietary heterocyclic amines generate genotoxic produce involves one member of the cytochrome superfamily, cytochrome P1A2, that's constitutively present in human and rats, but not in cynomolgus mongoose, it's experimental animals. Such species difference have crucial implication for the choice of species to be used to for toxicity and cancerogenicity testing during the development of new drug for use in human. So it's second phase. Phase 2 reaction, synthetic, it's anabolic and involve conjugation. For example, attachment of substituent group, which usually result in inactive products through their exception. For example, active sulfine metabolite of minoxidil. Phase 2 reaction take place mainly in liver. If drug molecule of phase 1 product has suitable handle triol amino group, for example, triol amino group, it's susceptible to conjugation. The chemical group inserted may be glucuronyl, sulfate, methyl, acetyl. The tripeptide glutathione conjugates drugs, or there phase 1 metabolism where it's sulfonyl sulfhydryl group. As in the detoxification of paracetamol, glucuronidation involves the formation of high energy phosphate. Its donor compound uridine diphosphate glucuronic acid, from which glucuronic acid is transferred to an electron-rich atom. It can be oxygen, serum, NO or S. On the substrate forming an amide, ester or triol bond. Several important endogenous substances, including bilirubin and adrenocorticosteroids, are conjugated by the SAM pathway. Acetylation and methylation reaction occur with acetyl coenzyme A and acid-adenylyl methionine, respectively, acting as a donor group. Many conjugation reactions occur in the liver, but other tissues, such as lung and kidney, are also involved. Hmm? Overall clearance of drug by all routes is a fundamental pharmacokinetic parameter describing drug elimination. It's defined as a volume of plasma which contains the total amount of drug that's removed from the body in until time. It's thus expressed as volume per unit time. For example, milliliter per minute or liter per hour. Renal clearance, important component of total clearance. So maybe this for many drugs, the separates from the plasma flowing an approximately exponential time course. Such drugs can be described by a model where the body is treated a single well-studied compartment of volume of distribution is an apparent volume linking the amount of drug in the body at any time to plasma concentration. Elimination half-life T1 to is directly proportional to volume of distribution and inversely proportional to total clearance. With repeated dosage or sustained delivery of a drug, the plasma concentration approaches a steady value within 3 to 5 plasma half-lives. In urgent situation, a loading dose may be needed to achieve therapeutic concentration rapidly. Look on these formulas and go to next slide. Simply defining the volume of distribution in the volume of plasma that will be necessary to account for the total amount of drug in the patient's body. If that drug were present throughout the body at the same concentration as found in the plasma, this value is usually further divided by the patient's body weight, and the result expressed in terms of liters per kilogram. Two-compartment model is often needed. In this case, the kinetics B exponential T. Here, two components role represents the processes of transfer between plasma and tissues, phase, and elimination from the body. Some drugs show non-exponential saturation kinetics with important clinical consequences, especially disproportional increase in steady state plasma concentration when daily dose is increased. Not all drugs work via receptors for endogenous mediators. Many therapeutic drugs exert their effects by combining with an enzyme or transport protein and interfering with its function. Examples include inhibitors of angiotensin converting enzyme and serotonin reuptake. They sites of drug action, not receptors in the sense of being sites of action of endogenous mediators. Whether the site of action of drug is receptor or other macromolecule binding, usually highly specific with precise steric recognition between the small molecular ligand and the binding site on its macromolecular target. Binding is usually reversible. Oxacionally, covalent bonds formed with irreversible loss of functions. For example, aspirin binding to cyclooxygenase. Most drugs produce graded concentration dose-related effect, which can be plotted as dose-response curve. Such curves are often approximately hyperbolic if plotted semi-logarithmically. This gives an S-shaped sigmoidal shape. This method of plotting dose response curves facilitates quantitative analysis of full agonists, antagonists, and partial agonists. Drugs are often potent and specific. For example, small changes in structure lead to profound changes in potency. High potency is a consequence of high binding affinity for specific macromolecular receptors. Receptors were originally classified by reference to the relative potencies of agonists and antagonists on preparation containing different receptors. The order of potency of isoprenaline, adrenaline, noradrenaline on T-rich in beta receptors, such as the heart, contrast with the receptor order in alpha receptor mediated responses such as vasoconstriction in resistance artery supplying the skin. So next, agonists activate receptor for endogenous mediators, for example, salbutamol is agonist at beta-2 adrenal receptor. The consequent effect may be excitatory, for example, increased heart rate, or inhibitory, for example, relaxation of airway smooth muscles. Agonists at nicotinic acetylcholine receptors exert an inhibitory effect by causing long-lasting depolarization and then neuromuscular junction and hence inactivation of the voltage-dependent sodium channel that initiate the action potential. Endogenous ligands have sometimes been discovered long after the drug that act on these receptors. Endorphins and enkephalins were discovered many years after morphine. And competitive and antagonist combined with some receptors as endogenous agonist. For example, ranitidine, histamine H2 receptor, but fail to activate it. When combined with the receptor, they prevent access of the endogenous mediator. The complex between competitive antagonist and receptor is reversible, provided that the dose of agonist is increased sufficiently. Maximal effect can still be obtained. For example, the antagonism is surmountable. If a dose of agonist causes a definite effect when administered alone, then the dose needed to produce some effect in the presence of antagonist is multiple, known as a dose ratio. This results in in the family parallel shift to the right of the log long dose response curve. Since the addiction of a constant length on logarithmic scale corresponds to multiplication by a constant factor. Some drugs combine with receptors and activate them, but incapable of eliciting maximal response, no matter how high their concentration may be. There are now as partial agonists and said to have low efficacy. Several partial agonists use therapeutics, including for example, buprenorphine. Full agonist can elicit maximal response when only small proportion of the receptors is occupied. But this is not the case with partial agonists. There are a substantial proportion of the receptors need to be occupied to cause a response. This has two clinical consequences. First, partial agonist antagonism. The effect of a full agonist, because most of the receptors occupied with low efficacy partial agonist, with which the full agonist must compete. Second, it's more difficult to reverse the effect of partial agonist. And prolonged exposure of receptors to agonists frequently occurs in therapeutic use, can cause down regulation or desensitization. Desensitization is sometimes specific for particular agonist. Or there may be cross desensitization, different agonist. Membrane receptors may become internalized. Alternatively, G protein mediated linkage between receptors and effector enzymes. For example, adenyl cyclase may be disrupted. Competitive antagonism. Plot of antagonist concentration gives a straight line through the origin. A long plot gives a straight line of unit slope. The potency of the antagonist is determined from the intercept of the child plot. Conversely, reduced exposure of a cell or tissue to an agonist result in increased receptor numbers and supersensitivity. Prolonged use of antagonists may produce analogous effect. One example of clinical important is increased beta adrenal receptor number following prolonged use of beta blockers. Abrupt drug withdrawal can lead to tachycardia and worsening angina in patients who are being treated for ischemic heart disease. In contrast to high potency, high selectivity drug, which combine with specific receptors, some drugs exert the effect via simple physical properties or chemical reactions due to their presence in some body compartments. Examples include antacid, osmotic diuretic, and bulk and lubrication laxatives. These agents of low potency and specificity and highly qualified drugs in the usual center at all through some of them useful medicines. Metal glazing agents used for example in the treatment of poisons with ferrous sulfate. Example of drugs that exert their effect through interaction with small molecular species rather than with macromolecular, yet which possess significant specificity. General anesthetics have low molar potency determined by their oil, water, pattern coefficient, and low specificity. Key points. I don't read it. I sent. Example case history with answer on this case. I thank you for your attention.
Thank you, Professor.
Thank you.
Thank you, Professor.
I stop our recording.